Good evening, everyone. I'm Dr. Hita Patel from IAP Digital Media Team. I'll be hosting the today's session that is on uh, case discussion or on the Vertigo, which is presented by Neurological Group of Indian Association of Physiotherapists. With the resource person, Dr. Meeta Tiwari, Dr. Zarna Ronak Shah, and Dr. Nazim Madam. The Indian Association of Physiotherapists is the oldest and largest association representing the physiotherapists in India since 1955. The IAP digital media team consists of the group of physios who handle the Zoom platform, webinar live streaming, and IAP profile on a social media platforms like Facebook, Instagram, Twitter, LinkedIn, YouTube. Follow IAP profile on the social media to receive notification for our events such as webinars, workshops, CMEs, conferences, health camps, blood donation drive, and to know about recent updates on physiotherapy. Subscribe to IAP YouTube channel for notification of our live webinars in playlists section of this channel. The social media link will be shared in the chat box shortly. So I'll be handing over this to our moderator, Dr. Shraddha Diwan Madam.
Thank you, Dr. Heta. Very warm welcome to all respected speakers, the office bearers of the IAP, and all the audiences. Myself, Dr. Shraddha Diwan, lecturer, SBB College of Physiotherapy, VS Hospital, Ahmedabad, Gujarat. On behalf of IAP, I welcome all of you. We know that World Physiotherapy is a global body of 121 physiotherapy member organizations. INPA, that is International Neurophysiotherapy Association, that is a recognized group of neurophysiotherapists in the world physiotherapy, and that was recognized in 2011. Indian Association of Physiotherapy is led by the visionary leaders, Dr. Sanjeev Jha sir, who is a president of IAP, Dr. Ruchi Vashne ma'am, who is a treasurer of IAP and the women cell, the organizing secretary of the World Physiotherapy Asia Western Pacific region, which is a regional conference of AWP 2026, going to be organized on 26th and 27th September of 2026 at Yashobhumi Convention Center, New Delhi. And we have our own Dr. Nehal Shah ma'am, who is AWP Vice Chair. So under this visionary leaders, we have formed the IAP Neuro subgroup. Neuro subgroup is a national group of physiotherapists with a special interest in the neurosciences. We are of 15 core group members, and we are focused to work to uplift and enlighten the field of neurophysiotherapy amongst the practicing physiotherapists, the medical professionals, as well as the rehab professionals. We are here with a series of case discussion on vertigo. And stay tuned and join the community for further updates of IAP Neuro subgroup. We have Dr. Sanjeev Jha sir with us. So let us listen a small message from Sanjeev Jha sir. Over to you, sir.
Thank you, Dr. Hita, Dr. Shraddha, and my colleagues, Dr. Ruchi Vasne, Dr. Snehal, Dr. Nehal Shah, and everyone in Neuro subgroup. I can not name everyone here, but this is really a very great initiative, and I think Neuro subgroup is leading as far as subgroups are concerned. And we have a aim that each and every specialty of physiotherapy in India should establish properly, and we should give more and more researches, more and more case discussions, and more scientific presentations from India on all over international platforms. Yes, as Shraddha Madam was saying, that we have a very important uh, milestone coming up for physiotherapy history in India. And why I say this as an important milestone, that because from here I feel that we will have one more big jump as far as physiotherapy profession is concerned in this country. We have done a hard work, and now these hard works, because we all together are doing that, these are paying now fruits now. And I think one of the very sweet fruit is Neuro subgroup. And we all need to take it more further, join more and more people. And I think not only the clinicians, not only the academicians, but also those students who have got a specific interest in neuro. So I think once we are through a very lively schedule of 1 year for each and every subgroup, that will, I think, fetch and really make a root connection to basic physiotherapy level in this country. So I will not take much time, and I should say a big thank to all of you. And I believe that these type of efforts from subgroup will always make a big change. And I know that in that subgroup, Dr. Dharam Pani Pandey and all, I think Dr. Amit is also there. And I can't name everyone, but as far as I remember, uh, I wish everyone very best from my side, and all the participants of best wishes from my side. Let's move the things ahead. And thanks for calling me here. Thank you.
Thank you so much, sir, for these inspiring words. Uh, a short message from Dr. Ruchi, ma'am. Yes, ma'am.
So, hi, good evening, everyone. So, good evening to the respected speakers, Dr. Jarna, Dr. Naseem, and the team of IAP Neuro Subgroup. Good evening, Jasar, and every participant who is attending today. It is a great initiative. Again, Vertigo or vertigo is basically, I feel, a very important topic to be discussed by physiotherapists, from physiotherapists and the surgeon. So it's important because these days we get a lot of patients, and if we have the knowledge from the experts, it would be great when the clinicians are treating, when the students are learning, and academicians are teaching. So I would like to congratulate the neuro subgroup of IAP, which is doing extremely well as far as the topics you are taking. It's excellent. I'm sure everybody will be benefited, and it's a kind of work which we were like dreaming of when we were student, that we should learn from the people who we look up to. And now we have a live on IAP India YouTube channel. With this, I would like to invite everybody also for this year, the making a history by making a world record in the World Physiotherapy Asia West Pacific Regional Conference. Everybody, every participant who's attending, please understand it is after 20 years that India is going to host it. And the world is excited about it because 9 months to go, and we have almost touched 4,500 registrations with more than 1,500 professionals joining in. I think it's for the first time happening in anywhere across the world, and therefore they are all excited. They are all coming to India, and we have to be a great host, and we have to show how physiotherapy is important in India. The dream of IAP, dream of Jasar, physiotherapy to physiopathy, again going ahead, and we will definitely get that. With this, I would like to again congratulate Suvarna ma'am, Dharam sir, Shraddha ma'am, Jaspreet madam, Sanjeevni, everybody who's here to encourage the team, to encourage the speakers hosting it, my digital IAP team, Dr. Uttara, Dr. Heta. Thank you so much, everyone, and have a great learning ahead. Thank you.
Thank you, Ruchi ma'am, for saying everyone's name. And I hope those names who uh, what I have missed, you have said everyone's name and you actually remember more better than me on this topic. So congratulations and thank you for saying
Thank you
that.
so much, sir.
Thanks and
Thank you.
all
Thank
the
you.
best
Bye.
from my side.
Thank you so much, Ruchi, ma'am, and Jasar. Without further ado, let me introduce our expert speakers. So, the first speaker is Dr. Meeta Tiwari. Dr. Meeta ma'am has done her MBBS from the BJ Medical College and her master's from VS General Hospital, NHL Municipal Medical College. She has worked as a senior resident in the ENT department of HIMS Medical College Varanasi, and currently she is working as a consultant ENT surgeon at Pluto Multi-Speciality Hospital Himmatnagar with a vast clinical experience on the vertigo. My second speaker is Dr. Jarna Shah ma'am, who is a PhD and MPT in the neurosciences. Madam has done proficiency in the EMG NCV from the American Academy of Clinical Electrodiagnosis with a special interest in the electrodiagnosis, stroke rehabilitation, and vestibular rehabilitation. Madam is working as a faculty at SBP College of Physiotherapy, AMC Medical Education Trust, Ahmedabad, and she is having more than 17 years of teaching and clinical experience. Madam has served as a founder vice president of the Gujarat State Council for Physiotherapy. Madam has conducted many workshops and webinars for the stroke as well as vestibular rehabilitation. Madam has presented multiple papers and posters in the national conferences and published many independent research papers in the index journals as well. And last but not the least, I warmly welcome Dr. Naseem Chatiwala. Madam Naseem is founder and owner of Rehab Health 360 at Massachusetts. Madam is a board certified neuroclinical physiotherapist and a certified vestibular clinical specialist with more than 20 years of clinical experience as a physical therapist treating variety of complex neurodiagnosis. Naseem graduated with a Bachelor of Physiotherapy from Gujarat University, India, Masters in Neurological Physical Therapy from MGH Institute of Health Professions in 2003, and a Doctor in Physical Therapy from MGH Institute in 2006. Naseem started her career in the United States in the Boston MA, where she worked for more than 10 years. Naseem later joined Emerson Hospital Concord MA Outpatient Rehab Center. Naseem has been instrumental in developing vestibular task force at Spalding Rehab Network and the Neuro and Concussion program at the Clock Family Center for Rehabilitation and the Sports Medicine. She has also helped develop guidelines for the balance clinic, vestibular screening, baseline concussion testing, and return to play protocols post concussion. So, with all this expertise of Naseem, we had pulled her, warmly welcomed her for the vestibular rehabilitation knowledge, and let us all have this knowledge fest from all the expert speakers. Thank you so much. With this, I would like to start the case discussion. I'm going to present a case of a female who is 49-year-old patient, and she had a complaint of dizziness while doing household tasks. These complaints are on and off since last 1 week. She does not have any complaint of the head trauma but had some kind of ear pain. And with the ear pain, she consults the ENT surgeon. So my case, the question to Dr. Meeta madam is, when such a kind of female comes to you with the complaint of dizziness, what would be your approach, ma'am?
Yeah, so many a times what I do practice in my OPD is many times patients complain dizziness with vertigo. So first thing which I ask them is if it is associated with any blackouts or sudden standing or prolonged standing, because sometimes all these are pre-syncopal symptoms. So sometimes patients complain, especially in Indian setup when females are majorly iron deficient anemic patients. So these are very common, and there's lightheadedness, everything due to all of those reasons, due to iron deficiency and due to syncope. So people confuse it with that. First of all, I ask them one question: do you feel a spinning sensation? Do you feel that you yourself are spinning or the surroundings are spinning? And then if when they say, when they confirm about it, then I progress further. I ask them if it is associated with any ear complaints. Sometimes it is associated with, sometimes patients give history that yes, they've had a recent history of upper respiratory tract infection few days before, and after that they're having earache or sometimes heaviness in ears, and then this giddiness. So in such cases, mostly for our the diagnosis is usually vestibular neuronitis or labyrinthitis it can be, which is usually self-resolving. But still, if the patient is having troublesome symptoms, then you have to give him labyrinth and sedatives like beta-histine or chlorprazine according to the patient's symptoms. Secondly, also one thing I ask to almost every patient is that are your symptoms related to the positional movements of your head? Like, does the giddiness comes when you toss around in your bed, or when you suddenly make jerky movements of your head, or something like that? And if he says, if that is the case, then most probably it is BPPV, that is benign paroxysmal positional vertigo. So for checking that, we do a small maneuver, which I think everybody is familiar with, is Dix-Hallpike test, and which help us to confirm if it is BPPV or not. And then if it is BPPV, if it comes out to be BPPV, then simple particle positioning maneuver according to the canal which is involved. And sometimes if the patient is also having complaints of the ringing sensation of the ear, episodic tinnitus, like जब चक्कर आता है मैम तब मुझे कान में सीटी सी आवाज आती है, then when the symptoms subside, it also subsides, but there is constant feeling of oral fullness. Then it can be Meniere's disease also, which is basically due to increased fluid in the inner ear. So basically the diagnosis is all symptomatic, and depending upon the symptoms. And finally, after getting a complete detailed symptoms history and everything, secondly you have to ask whether the patient is on any medications like thyroid or diabetic medications or antihypertensive medications, because sometimes all these conditions, hypoglycemia, hyperglycemia, hypertension, they also lead to this vertigo complaint. And finally, I usually check, or I do auto endoscopy of both ears. Sometimes what happens is that the patient has a perforation in their ear. So basically the middle ear mucosa is exposed to outside. And so it is very vulnerable to infections. Whenever a single drop of water even enters, it gets infected. And as we know, in the middle ear, there is our labyrinth wall is situated. So if it get infected, then there is a chance of labyrinthitis. Also, sometimes there is a cholesteatoma in the middle ear. We say it unsafe CSOM. So basically, to rule out this causes, we have to do the endoscopy. If the endoscopy comes out to be normal, then we go for the symptoms. Like if it is BPPV, we do the particle positioning, all the maneuvers, and otherwise mostly it is symptomatic treatment we give. Also, we have to rule out whether it is central or not, because if it comes to be, because if the symptoms are like nystagmus, which is basically upward beating nystagmus, also we do the nystagmus test also in the OPD. And if the nystagmus comes out to be vertical beating nystagmus, or patient has some problems in the gait or slurring of speech or limb weakness, ataxia, everything, then it points to something more central. And if it is central, then I have to refer it to a neurophysician or something like that. Sorry, you're not audible.
Yes. So that was my second question to you. What are the indications that to refer the patient to a neurologist? You have already answered, ma'am. Any one of you want to answer for that? The indicators that refer the patient to the neurologist. The central ataxia is there, or it is vertical nystagmus, which are the hallmark of the central causes, right? Okay, my third question.
Okay,
Yes, ma'am.
No, just continue.
Yeah. So my third question to Dr. Jarna is, what simple questions do you ask are the key question to a patient for the clarity of clinical condition? Few important key questions are there which you will ask to the female who is having the dizziness.
Thank you, Shraddha Madam, for the question. As Meeta Madam has already specified few questions related with vestibular dysfunction, but it is as per the ENT surgeon's purview. When I, as a neurophysiotherapist, get a patient with dizziness, I ask a few questions. The first question is, do you feel that the surrounding is moving, or you feel that you are moving? This is the first key question which I always ask patient. If I have seen in my practice that majority of the peripheral vestibular disorder patients say that the surrounding is moving. Meeta madam can also correct me if I am wrong. And then I ask a few questions like, do you have any associated symptoms like you have nausea, you feel like vomiting, or you have imbalance, or you have tinnitus or some sound in your ear? Such associated symptoms, if the patient has, then also I evaluate or I ask patient. The next question is, do you have headache with this or not? And what are the relieving factors, what are the aggravating factors, since when the patient is having these symptoms, are they progressive in nature, uh, is patient taking some medicines or not? But basically, if we are dealing with benign positional vertigo patients, then the key question is, does the movement of neck aggravating your symptoms? That means while turning in the bed, or while lying down in the bed, or getting up from the bed. These are the two main questions we ask. If the patient says that yes, the position of the head is aggravating the symptoms, that is indicating more towards BPPV, and then we progress with our management.
Yes, thank you so much, Jarna ma'am, for highlighting those important key questions. Now, my question to Naseem: what are the clinical tests to be performed for the assessment and suspected BPPV as a neurophysiotherapist?
Thank you. So I think we start with again the same thing as Dr. Meeta and Dr. Jarna already said. So first is, if somebody comes with dizziness, we want to first rule out any red flags. So is it something that I can treat them in my clinic, or do I have to send them out to 911 or to an emergency room? And so Dr. Meeta kind of said about like stroke symptoms. And then as Dr. Jarna said about key questions, right? Like we want to understand what that dizziness is. So is it like a room spinning, or is it something like pre-syncope, as Dr. Meeta said? Because it could be a blood pressure issue, it could be a medication issue, or it is like disequilibrium, like being on a boat all the time. A lot of patients over here like to go on boat rides, and they come back, or they are in a flight and there was like a really bad weather and the flight was moving everywhere, and they come back feeling like really dizzy and disoriented. So trying to get some more history. Another question, key question that Dr. Meeta suggested was, did they have any kind of infection, like a viral infection? Because that could be a predisposing neuritis or a labyrinthitis kind of a thing. Once the patient comes in, I usually like to start with something called a dizziness handicap inventory. It's like a 25 question subjective questionnaire. And basically, it tells me is, when is the biggest problem with movement, right? As Dr. Jarna said, is it the head moving in relation to gravity? Is that what's causing the problem? Are you getting really dizzy when you're getting out of the bed, when you're getting in the bed? But then what I like about dizziness handicap inventory is it also looks at the psychological and emotional part of your patient. Because these patients who have dizziness or vertigo, it's very hard for them to explain to another person what they're going through. And so they look pretty put together, and they might just feel really bad in their head, but they cannot say it out to friends and family. And so people don't understand how to support them. So direct off questions: are you depressed? Are you able to be in home by yourself? Can you walk by yourself? Can you go out to a grocery store by yourself? Can you walk on a sidewalk by yourself? So I think those kind of questions, and because as physiotherapists, right, we are like movement experts and we really think about function. So we'll restore BPPV, but then how do we restore fear and confidence? So that's something I really always want to put that into perspective. Once we do the dizziness handicap inventory, it gives me a number between 0 and 100. Higher number is more disability, lower number is less disability. And so that will give me a little point about where to start. Then the first thing I always do is look at neck range of motion. Sometimes, because as we know that these crystals move with the head position in relation to gravity, I like to screen what is the neck extension, flexion, and then rotation. And then there is something called a quadrant test, which may or may not be, sorry, I should have got my phone. The quadrant test is basically just trying to say that we are not interfering with any of the vertebral basilar artery insufficiency. So we just kind of have the patient bring their head forward, turn about 45 degrees, look up to the ceiling, and then count backwards by 10. And we are not saying positive or negative. All we are saying is by doing this position, patient had no complaints about anything else, right? The 5 signs of D, like diplopia, dysphagia, dysarthria, those kind of things. So we're just kind of ruling it out. And then we would go into doing an oculomotor exam. And for oculomotor exam, I usually like to just do a quick smooth pursuit, just to make sure that there is nothing central signs going on. I look at saccades, so just like again reaction time, because again I see patients who have Parkinson's, and they might already have a slowed saccadic movement, and then they might have something on top of it. So just to rule it out. I also look at convergence, because a lot of times I treat a lot of older adults, and they fall, and they may have hit their head, and they may have a concussion on top of BPPV. I would do a head impulse test, and the head impulse test is again just to rule out a peripheral vestibulo-ocular reflex functioning, like a gaze stability. So you just move your head side to side, and then you move it fast, and you see if your eyes were able to stay on the target or not. Once I screen all of that, making sure that nothing else is going on, then I would go in and do a positional test, which is Dix-Hallpike test. Is it okay if I share my screen?
Yes, sure.
Okay. So I'm just going to go through a quick thing about sorry. All right, so again, just going back, we kind of differentiated what it is, right? Is it vertigo? Is it a true spinning or lightheaded or swaying or disequilibrium? This is that dizziness handicap inventory. It's freely available. You just Google search it, and I usually just have it printed. And as soon as a patient comes in, I always give this questionnaire first to the patient, and they will write down yes, sometimes no. Yes is a 3, sometimes is a 0, 1, 2 stuff. And then, as Dr. Meeta kind of mentioned about this, is we are like trying to differentially diagnose. Is it central? Is it peripheral, right? So we have like somebody's coming acute origin of dizziness. Then could it be an infection? Can it be BPPV? But if somebody has a chronic issue, then can it be cervicogenic? A lot of times patients have stiff necks. They have arthritis. They don't have movement in their necks. So could that be contributing to this? Again, we're just trying to differentially diagnose here, but we kind of covered a lot of these already. This is the head impulse test. So you just move the head side to side, and then you go fast. And if it is a negative test, means that the eyes will fixate on your target. If it's a positive test, means the eyes will not stay on the target. And then here's where we get into positional testing for the canals. Now, as Dr. Jharna and Dr. Meeta mentioned, that we have 3 different canals, right? So we have the posterior canal, anterior canal, and the horizontal canal. I just recently got a really nice little thing to explain to my patients, because I feel education and explaining is so good. So basically, if I have these 3 different canals in here, every test, positional test, will only figure out if the crystals are in one of these canals. So I would start with a Dix-Hallpike, because we know that the posterior canal is the most involved. So as soon as I lay the patient down, I'm going to see if they have 2 things. One is vertigo, how long it lasts, when it starts, and then the direction of the nystagmus. Is it going upbeat? Is it going downbeat? Because if it's upbeat, it's the posterior canal. If it's downbeat, it's the anterior canal on the other side. If it is sooner onset, so there is no latency, then it is cupulolithiasis, meaning the crystals are stuck to the cupula. But if there is a latency, then it is canalithiasis, meaning the crystals are moving in the canal. And we have different treatments for each of them. So that's, sorry, it was long, but
Yes, Dr. Naseem.
Yes, so that was the assessment piece.
Yeah.
Is that how we would get to the assessment?
Yes. Yes. Okay. Now coming to Dr. Meeta once again. Ma'am, if it is a suspected BPPV only, then what would be the management strategies?
If it is BPPV only, as Naseem ma'am has told, first we have to find out in which canal, due to which canal otoconia this is caused. And for each canal, there are different particle positioning maneuvers and different diagnosis tests. So mostly we use the particle positioning maneuvers, and if along with it we also have to give symptomatic treatment because it is this vertigo is very troublesome for the patient. So we give some labyrinthine sedatives like the beta histine or prochlorperazine, which is most commonly used, Stemetil or Vertin. And once the acute phase passes off, we explain the patient about this vertigo exercises in the maintenance period. So yeah, that is how we do it.
Okay. My question to Dr. Naseem, what are the treatment strategies for the patient when she actually is passing through the vertigo symptoms?
Uh, so, as Dr. Meeta mentioned, right, we have different treatments for different things. And if I do a Dix-Hallpike test, and if I have somebody that I diagnose as canalithiasis for the posterior canal, then there is we call it a canalith repositioning maneuver, which is like an Epley's maneuver. But with Dr. Epley, he used like vibration for moving the particles, because think about it, these are the particles which need to move from one end of the canal to the other side, right? So we are bringing this patient down into the Dix-Hallpike, and I don't know if you can see these little red particles traveling. So this is your Dix-Hallpike, but see how slowly they are moving because of endolymphatic fluid has high viscosity. But if I had a tuning fork and I put a vibration sense over here, then because of that vibration, possibly this might go faster. At least that was what was thought in that older theory. But we don't use vibration for all our patients. So that's why we don't call it Epley's maneuver, and we don't pre-medicate all our patients. And after we do the maneuver, we don't tell them to sit upright for 3 days. So that's why we don't call it Epley's maneuver anymore. But it's kind of the same thing, right? You will bring your patient down, you hold it till they feel better. That means you have given a chance for all the crystals to move to this one spot. We give them additional 10 seconds. Then we turn the head to the other side. Same thing again, we wait till the crystals follow. Then we roll them and bring their head down towards 45 degrees towards the ground. Stay there again till the symptoms subside, additional 10 seconds. Then we would chin tuck and then slowly bring the patient up. And I have a little video I can show there. So this is like a video where we did the assessment, right? So when I got the patient in Dix-Hallpike, then we also look at the eyes, and this is what I was telling you about. If it's upbeat, I know it's the posterior canal.
Yeah. Open your eyes and keep your eyes open, please, for the whole time. Sorry. Yeah. Because that's how I call the scene. No, I know. One, two.
So you see how the eyes are moving?
Yes. Wow. Yes. Please.
And as Dr. Meeta mentioned, right, these people are very symptomatic. So sometimes we have to medicate them.
Which canal is that? Right, posterior.
And so this tells us about the canal is involved. This is just another test. It's called a sideline test. So sometimes when you have to do a Dix-Hallpike, you turn your head one side and you have to lay flat back. But suppose if somebody had ankylosing spondylitis, or they have Down syndrome and they have ligament laxity, or they have back pain, or they have a back surgery, then we may not be able to do a Dix-Hallpike. So this is an alternate test where, again, all we're trying to do is we're trying to move the head in relation to gravity to see if they have crystals in one of those canals. And then the treatment is, they have crystals over here. This is the right posterior. You would bring the patient down in that little Dix-Hallpike position. So you're moving the crystals. Then from facing right, you have them face left. And then from this position, you have them roll over And this is that head about 45 degrees from the ground. Once you are done, you are essentially done. Then you have your patient chin tuck and then slowly sit up. So you're starting here, you go down, you hold this here, patient is feeling better. Then we slowly turn the head to the other side. Again, we hold it. And again, it has to be done nice and slow. We don't have to jerk the neck. We don't have to go too fast, but we have to go in a relatively good speed so everything keeps flowing. And then we would chin tuck. And then we would slowly sit up. And we are done. So this is about the posterior canal.
Okay, my next question to Dr. Jharna is, what can be the long-term plan and treatment strategies for patient with BPPV? Do they feel any long-term issues, or it is such a acute episode only?
Yes, madam. Actually, in acute episodes, as the other experts have said, that few maneuvers are there which can reposition the crystals inside the canals, and also medications are required because it is very much troublesome to the patients. But when we see as a long-term management, we make them habituated with the aggravating positions. So basically, we give them self repositioning exercises, which we practice in our OPD is basically brand of exercise. And this brand of exercises are very safe because it is self repositioning. And whenever the patient is feeling uncomfortable or uneasy or not able to perform it, we do not force them because it has to be performed even at home, where even nobody, I mean, medical professionals may not be there at home. So we ask them to do it even when only they feel comfortable at home. Another thing is habituation exercises. We give them oculomotor training, which is optokinetic training. So we teach them all the ocular motions, first with keeping the head in neutral. Then we ask them to move the head, keeping the gaze stable. And then we ask them to go for more challenging while looking to the other side and moving the neck to the other side. Another thing is we also teach them active neck range of motion because neck position will aggravate the symptoms. So active neck range of motion and the provocating position we ask them to perform so that it will make them habituated. Sometimes the patients of vestibular dysfunction also presents with imbalance. So for that, we teach them balance training, which we are much aware about standing balance or dynamic standing balance training. That is the long-term management we give. Thank you.
Thank you for the insightful answer, ma'am. Now, my question to Dr. Naseem is, what are the latest evidences for the vestibular rehabilitation?
Sorry.
Naseem?
So,
Yeah.
yes, for BPPV, like there is tons and tons of evidence. So there is this clinical practice guidelines, which was published by Bhattacharya and their group, and they initially came out in 2008, and then they had another one published in 2017. It's almost like 8 years. So usually every 10 years, they're going to do a review and rebring. But what they are saying is that we as physical therapists should assess somebody who has dizziness and vertigo. We should put them in provoking positional test. And sometimes it's scary. Like I find patients come and they will be like, please don't do that to me. I went somewhere else and they put me down and it was the worst feeling ever. So I think education is a big thing, which is what the clinical practice guidelines is telling us, is this is a very scary thing for the patient. Patient is thinking they're having a stroke. Patient is thinking they're going to die. Because if you get up in the middle of the night and you have that severe spin episode, it's very scary. So education about what it is, I always tell them that it's a plumbing issue. Because think about it, your pipes got clogged with crystals, right? Like you have these nice flowing fluid in this pipe, and from somewhere these calcium carbonate particles came, these crystals are clogging these pipes. And then we are just going to do these physical maneuvers, which are going to bring these particles out of the tube back to the vestibule, and then they get absorbed or broken down, and then that's it. It's a magical treatment. So I think that education piece is a very, very big thing, which the clinical practice guidelines is telling us to do. The other thing that the evidence is showing us is we do not need to use vibration for every patient. But I have patients, it's very stuck, it's very stubborn. They've had BPPV for 20 years. And so I might have to use. So I think knowing the evidence is great, but then having your own clinical experience, and then also looking at what your patient is and patient's perspective, and then coming with an informed decision of what you're doing and how you want to do it. Same thing with medication. Clinical practice guidelines are telling us we should not medicate our patients, like pre-medicate. But as we all know that some of these patients, it's just very hard for them to even move around. If they're so nauseous, they're throwing up, we might want to pre-medicate them. We might want to suppress their vestibular system a little bit. Yeah, so that's about BPPV evidence. And then there is a whole other clinical practice guidelines for hypofunction evidence.
Yes, Dr. Meeta, you want to share something about the evidence-based practice?
No, not really.
Okay. And now again, the question to Dr. Jarna and Dr. Naseem both. What differences in neurophysiotherapy practices do you find in India versus USA? Yes, Jarna, you can start, I think.
Yes, thank you, madam. But actually, I think I cannot say exact difference because I have not treated any patient in USA, but I have seen patients in India. In our setup, patients are very much worried because when I ask them, how have you come to our department? They are mostly alone or they have come by two-wheeler. So basically, personally, I feel that if I give any maneuver and if it aggravates the symptom, then it will become difficult for the patient to go back to home. So we always, in our practice, try to give them self-repositioning maneuvers, which are safe. And also we ask them if at all we give any maneuver, then we always make sure that the patient sits at least in our department for 30 to 40 minutes and without any symptoms. That is we always practice. But basically in India, in Gujarat, I have seen that they are not much aware about vestibular rehabilitation, but once we give them exercises, they are so benefited. And they used to come only for once that a neurologist or ENT surgeon has referred us for vestibular rehabilitation, but then they used to come to us for these exercises, and they practice also at home because they find it very much helpful. So this is the scenario in India.
Yes, that's true. Yes, Naseem.
It's not very different over here. It's very
Yeah.
similar. And so most times when patients come, right, and again, that people live alone, so we will usually ask them, I think one of the questions that I think Dr. Jarna had mentioned earlier was asking them about nausea and motion sensitivity. And I usually will always ask them is, how are you as a child? Because you know how all of us, we have a different vestibular system. Like I can never go on a roller coaster ride. I cannot even see my kids going on a roller coaster ride. So my system is very sensitive. Whereas I have my daughter who can go on multiple roller coaster rides, no problem at all. So now if me and my daughter both had BPPV, I possibly may be throwing up because my sensitive system is already very sensitive. Versus my daughter will be like, oh, that was fun. Let's do it again. And so when you have patients, that happens. Sometimes you do a maneuver and they just jump up and they are ready to drive and go to work and they'll do everything. And then you have certain patients, we do the maneuver and they're like shivering. And I have had to call 911 because their blood pressure drops. It's almost like a panic attack that comes out of it. And so I think that education, again, knowing your patient as a person first and explaining to them. I also demonstrate the maneuvers to them so that they know exactly what I'm going to do. A lot of ginger ale or ginger gum and ice on the neck. But I think that kind of helps with doing it. And second, about awareness, I fight over here as well. I think it has gotten better, but so many people don't know about vertigo or BPPV or what we do. And so I think just educating everybody and because it's such a simple and easy treatment and it makes a full change, like it's a 360-degree change in our patients. So I think it's a really a good treatment to do.
Okay, now there are few questions in the chat box. I'm just sharing the questions. Any one of you can take up. So the first question is, are there different tests for the different canals? Different tests for the different canals?
Yeah, I can
It
take
is,
it.
yeah.
So there are different tests for the different canals. So basically, as we said, like we have like 3 different canals. And so the test is putting the canal in the most provoked position. So if you think about posterior canal, it's like 45 degrees. So you turn your head 45 and you go down. So that's the most provoked for the posterior canal. For the horizontal canal, it's like 30 degrees upwards. So you are supine, you kind of bring your head slightly forward. So you bring it in a gravity plane and then you just roll to the right, center, roll to the left, center. So that's a test for the horizontal canals. And then for the anterior canal, because it sits on the top over here, but it's like 30 degrees, it's not exact 45. So then the deep extension. So you're supine, you start with 30 degrees flexion, and then you go into deep extension and see what happens. So yes, there are different tests and different treatments for each of the canals.
Thank you, Naseem, for that answer. The second question is, how to treat apogeotropic nystagmus with direction changing nystagmus? I repeat the question. The question is, how to treat apogeotropic nystagmus with direction changing nystagmus?
I don't know if Dr. Jarna or Dr. Meeta want to take this question.
No, not even Pogiotropic nystagmus, I don't know.
Okay, fine. The
I
other
can
question
take
is,
this question. Actually, I can answer a little bit very shortly. So,
yeah.
two different things. Direction changing nystagmus is very different than apogeotropic nystagmus. So, I think the reason you are thinking about direction changing is because the only time you will see apogeotropic is I'm supine, I go to the right, you might see a upbeat nystagmus, which is apogeotropic. I come back center, I go to the left, and you will again see an apogeotropic nystagmus, right? So that might confuse you as being direction changing. But in the BPPV world, we only call it apogeotropic. We don't call it direction changing. And if it is apogeotropic, means it is cupulolithiasis of the horizontal or lateral canal. And cupulolithiasis means it's stuck in that canal. And so you have to do a Guffoni maneuver for apogeotropic presentation. And it's a very, very easy thing. You just go on the less involved side and then you look up to the ceiling. If you find it, like I think once you diagnose it and then you find it, you will be able to successfully treat that.
Thank you, Naseem, for that answer. I hope it solves the query. Now, the next question is, how do you modify the vestibular rehab for elderly patients to reduce the fall risk?
I would like to answer the question. Just a second. Yes, so for elderly patients having the risk of fall, basically, the particularly for vertigo, whatever we are giving, that is not related with fall, so there is nothing to worry. But if we are giving them balance exercises, then it has to be given under supervision. And even if they are practicing all the vestibular rehabilitation exercises at home, then we ask them to do it when somebody is nearby to them, so that we try to avoid the risk of fall. So we ask them not to perform it alone, because many a times the exercises may provoke the symptoms, as even Dr. Naseem has told that the symptoms may get worsen with the maneuvers or exercises, because it is actually habituation exercises to BPPV. So we ask them to be under supervision at home also. And for fall, we assess the risk of fall first, which are the risks, and then we try to manage accordingly.
Thank you, Jarna ma'am. The next question is, are there any known complications after correcting maneuver?
I can take this.
Yes. Or
Maybe
should I repeat the
Dr.
question? Yeah.
I got it. Maybe Dr. Meeta or Dr. Jhanna want to add to this, please feel free. But not usually. So basically, and that's why the pre-screening is very important. So we always check blood pressure, because if somebody has high blood pressure, like you are putting your head below your heart. And so we want to make sure that your blood pressure is okay. I once had a patient who was referred to me who had a concussion. She had fallen down. And she actually, when we got her scan, she had a hematoma, and she was referred to us for BPPV treatment. But because she had coordination issues, I was like, I'm not going to do the maneuvers for her. So definitely looking at your screening before you would put them in a position. But after you have done the maneuver, the only side effect could be is you are treating somebody for posterior canal and you dump the crystals out of posterior, but they have gone into a horizontal or an anterior canal. It happens. And it's nothing that you as a clinician did wrong. It's just that the anatomy of these canals was such, because they don't have any doors. So it's very easy for them to slide from. And if that happens, it's not a big deal at all. You reassess. It's a horizontal canal and it's a treatment, which is another maneuver, and you get them better. So that's the only kind of a complication. I get some people, I just prepare them that they may not feel well for the rest of the day, because when we put them down, the eyes are like jumping everywhere and they just feel exhausted and tired. But after 3-4 hours of TLC, tender loving care, they feel better.
Yes, the next question is, while checking for the neck range of motion, if the patient feels sudden dizziness due to head movements, do we still continue checking the ranges? What is the significance of neck ranges? Should I read the question again?
Yes, ma'am. Kindly repeat the question.
Yes. The question is, while checking for the neck range of motion, if the patient feels sudden dizziness due to head movements, do we still continue checking the ranges? And what is the significance of neck ranges?
Checking the range particularly is not important in vestibular dysfunction assessment. We check the provocating position. So we don't deal with range of motion basically. And if that is while assessing any musculoskeletal condition, and while checking cervical range of motion, if patient is having dizziness or any other symptom, that is signifying that the patient is having peripheral vestibular dysfunction. So we have to go further, and we might have to refer the patient to ENT surgeon or neurologist. But for vestibular dysfunction, I guess the range of motions are not important.
Naseem, you want to add on anything?
Yeah, so I absolutely agree with Dr. Jarna. And then sometimes what I will also do is I'll go really slow. So a lot of times the dizziness happens when things move fast, because it's all about how everything moves in this canal. So instead, if you go like really, really slowly and in a controlled environment, then it should not set off that dizziness. And it's not going to come like right away saying, I'm going to get very dizzy, because as soon as you go, the patient might say, oh, it's coming. And okay, so if it's coming, then we'll stop right there. So that's how we would do it. But usually that just gives us one more additional piece of information, because it could also be cervicogenic part to this, and we might want to treat it.
Yeah. Then the next question is, how to manage if the patient start having breathlessness? Have you
Is that
ever noticed, yes, such a kind of patient? During the evaluation or during the maneuver, the patient had breathlessness?
Yes,
I can speak
patient.
for. Go ahead,
Yes,
Dr.
Dr.
Meeta.
Meeta.
Yeah, I'm just saying that sometimes, as we have previously discussed, that sometimes these maneuver may lead to increased symptoms. So sometimes the patient goes into the panic mode, and all those panic symptoms like sweating profusely and breathlessness, and the symptoms like those do come, but you have to do the proper counseling, and it usually it resolves on its own. That's it.
Okay. One more question. Is vertigo seen in younger adults?
Young
Of course,
adults.
we see in young adults also.
Yeah.
I've
Okay.
seen
The
it
next.
as young as an 8-year-old. That's my youngest person I've seen a vertigo in.
Oh, nice.
8 to
Okay.
110. That's my patient age group.
Okay. Then the question is how to treat vertigo in, sorry, how to differentiate between cervicogenic and vestibular vertigo?
Um,
Yes, as we discussed, like the vestibular vertigo is sudden neck movements. Then, with all these maneuvers, you can confirm it. Also, the vestibular vertigo, if it is BPPV or vestibular neuronitis, something, it will be associated with ear complaints also. It may or may not be associated, and it is usually of short duration. Unless until it is Benjo's disease or something, it is short lasting. So if you ask the patient, K vertigo, does the vertigo starts on a specific head movements or a particular sudden jerky movements, and then it resolves after how much time? Usually it is within 3 minutes, it resolves on its own. So yeah.
That's really
Okay.
good. What we do with what Dr. Meeta mentioned, right? So then that's like the subjective part which we know. And then as physical therapist, there is also one test you can do to confirm if it is or not. So it's called head on body maneuver. Meaning if you're sitting over here and first you'll keep your body right here and you just move your neck and see if you're getting dizzy or not dizzy. And if you're getting dizzy, just note that. Then you keep your head and body all together as one unit and now move the entire body and see if you're getting dizzy or not. So if you're getting dizzy with your entire body, that means it can be vestibular because your neck did not move at all. But if your body was over here and only your lower body was moving, then that means you know that it's your neck. So it's just a differentiator. It doesn't have a lot of sensitivity or specificity, but just another tool in your toolbox to add to what Dr. Meeta mentioned.
I think it was a very insightful case discussion on the vertigo. We had almost discussed each and every aspect of the vertigo with the differential diagnosis, the assessment maneuvers, the treatment strategies, and a lot many questions are still there, but we are running short of time. So I would like to end the session over with a thanks note. I take this opportunity on behalf of Indian Association of Physiotherapy Neuro subgroup to convey my sincere gratitude to all the three respected speakers for sharing that excellent knowledge on the suspected case of vertigo and enlighten every one of us on the vertigo. Thank you so much, everyone.
Thank you so much,
Thank you
Shraddha
so much.
ma'am,
Thank you.
Thank you,
This was
Meeta ma'am.
and all the
Thank
informative.
you, Shraddha.
speakers.
Okay.